Okay, folks, let's go ahead now with the second half of chapter 8. Sorry I couldn't do that all in one setting. A little busy clinically here, but we're doing okay. So let's go to the second half of Unit 8, Chapter 8, rather. And we are at the level of shunt now. So you need to know that the system is not perfect. We all have a certain amount of shunt. That is unoxygenated blood leaving the right ventricle and going through the pulmonary system, returning to the atria without picking up oxygen. Another way of saying this is that the lungs need their own blood supply. They're doing a very important thing, bringing in oxygen, getting carbon dioxide out, but they also need their own blood supply. So there's a certain amount of just sort of normal shunt. We could call it venous admixture. And we think that's about 5%. So let's just throw that in here that it is normally about 5%. So let's see, get up there. Normally about 5%. And that will come into play when you're analyzing patients and trying to decide, what to do for them. But for right now, know that the system is not completely perfect. Absolute shunts or total shunts are made up of the sum of capillary and anatomic shunts. Capillary shunts are blood that bypasses the pulmonary capillaries, unventilated alveoli, systemic blood supply to the airways themselves, or deoxygenated blood flowing directly from pulmonary arterioles through anastomoses. Those are connections between uh, vessels. So they bypass. That's the thing. That's the word. That's probably the word to highlight for you is that shunt bypasses the mechanism for picking up oxygen. So there will always be about 5% of that. It's not a perfect system. Anatomic shunt, maybe 2 to 3% of cardiac output. In normal lungs, bronchial pleural and something called a Thebesian vein flows into the pulmonary veins in the left atrium. So what you need to know is that there is just a little bit of imperfection in the system. We're never going to get 100% of the blood oxygenated. That's all you really need to know for now. There are sometimes congenital defects of these large vessels that carry, the aorta, the pulmonary veins, pulmonary arteries. One is called tetralogy of Fallot. It's a congenital defect. If any of you happen to know the late night host Jimmy Kimmel, Jimmy's son was born with this condition, and he sort of educated the whole country about it as his son was going through that. Is now corrected and everything going well, but it is four defects. That's the tetralogy is four defects that happen simultaneously. You'll learn about those later. But there's also an absolute shunt called the patent ductus arteriosus, or PDA, and that is a very common thing we deal with in some newborns where the opening that needs to be there when the child is developing in mom allows mom's blood to circulate through the baby. For some reason, that doesn't close. And when it doesn't close, we've got to get it closed somehow. And that can be done a variety of ways that you'll learn about. There maybe have to be a surgical repair, but there's some little tricks we also have to maybe get it to close. These are intrapulmonary shunts. Here is circulation of blood through the heart, and you can see the path and also, oh, you know what? That's a very valuable thing right there because it gives you step by step the whole path: right atrium, right ventricle, pulmonary artery, lungs, left atrium, left ventricle, aorta, rest of the body, and then back to the heart and start it all over again. So that is actually a very useful little thing right there. Might take a look at that before you do the midterm. The ductus arteriosus, okay, we're going to talk about it more. Ductus arteriosus is an opening between the fetus's aorta and pulmonary artery, and it should be there while the child is developing inside a mom. Normally, within the first 12 hours of life, and actually sometimes with the very first breath, that thing closes because the child no longer needs it. He has his own, or she has her own oxygen supply from breathing. But in some kids, it stays open. It's called PDA, patent ductus arteriosus. The blood flows from the aorta to the pulmonary artery, resulting in a left to right shunt. So we got to get that thing fixed. Uh, there's actually a common medication that you guys have all probably used called ibuprofen. And somebody discovered that if you give these kids ibuprofen, sometimes that will reduce the inflammation and allow the ductus to close. How simple of a solution is that? But if that doesn't work, then we're going to have to go tie it off. And that's a fascinating thing that you will assist with. The pediatric cardiologist will be doing it right there in the neonatal intensive care unit, and you'll be breathing for the baby while that's happening. Relative shunting occurs when perfusion in the pulmonary capillaries is greater than ventilation. So we got more blood flow than we do ventilation. That's all you need to know about that. There is a long-winded shunt equation let's see if it's on the next slide. Well, that's the alveolar gas equation, which is more important by far. You will not have to actually be able to calculate the shunt equation. It's too much to do on an exam. Um, but this next piece, the alveolar gas equation, you will need to do. You will need to know that formula for sure. I'm surprised that it's in our very first course, but it's awesome because that'll give you a head start for the future. And there it is. The big AO2, that's alveolar oxygen, is barometric pressure, that's PB, minus water vapor pressure times the FiO2, that's the percentage of oxygen that the patient is on, minus the PaCO2, that's the arterial carbon dioxide, divided by the respiratory quotient, which is normally about 0.8. So that's it. That's the alveolar gas equation. You might as well learn it now. You're definitely going to need it when you get to critical care class and then for your board exams. This is the CaO2 formula, and right now it's being used to calculate CCO2, which is the capillary oxygen. Excuse me. Hemoglobin times 1.34 times the oxygen saturation plus the big AO2 that you just calculated from the alveolar gas equation times 0.003. And that is another formula that you will need. Here's the good news. There are only about a handful, I would say, 4 or 5 major calculations that you need to know how to do, but that's one of them. So that was CCO2 capillary. This is CaO2 arterial, and CVO2. I knew that was going to be next, is venous. Sometimes we're very interested in the difference between arterial and venous content. That's the C. So you needn't memorize those formulas right now, but you're going to need them when you get to a critical care class. Let's see here. Nothing new on that. That's the shunt. Shunt is CCO2 minus CaO2 and CCO2 minus CVO2. You divide the two. QSQT is maybe a weird way to express it, but that is how we abbreviate shunt. It means what percentage of total blood flow is shunted. All right. I'm sure that seemed like a lot. Don't worry, for this exam, you're not going to have to do those calculations, but we might as well get these formulas started in your head because, these are important ones you're going to need to understand. Alveolar gas, shunt of less than 10% considered normal. We said 5% is typical. Anything less than 10 is considered normal. 11 to 20 is a pulmonary problem, but over 21 is where you're really getting into a dangerous situation, significant cardiopulmonary impairment. Greater than 30%, we would say, is an emergency and requires immediate treatment. So shunt greater than 30 is probably the number you should come away with is a serious situation requiring emergency treatment. Shunt, well, we've talked about shunt versus dead space. Yeah. Shunt describes the flow of blood through the pulmonary capillaries around an alveolus that is underventilated. So that's alveoli that are being ventilated but do not have enough blood flow. It's ventilation without perfusion. Ventilation without perfusion. Okay, pulmonary blood flow is affected by a lot of different things: gravity, body position. It even makes a difference as to whether you're standing or seated or lying down. Um, but the pressure and the flow taking place in the lungs is different at different levels of the lungs. That's about all you need to know for that right now. They're called lung zones, and there are really three zones. These are called West's lung zones. West was the physiologist who described this. Yeah. So normally we have a certain amount of ventilation which does not match perfusion, and that's called dead space. It's ventilation without perfusion. It's the opposite. Dead space is the opposite of shunt. This is the three lung zones, which is more than you need to know right now. But I think it is useful for you to know that there are three lung zones. And there's a picture of them and how the pressures are different at the different lung zones. You'll learn more about that. The top of the lungs tend to have some dead space, and the bottom of the lungs tend to have some shunt. And that's just because there's more blood flow based on gravity to the bottom and more ventilation based on air going up. Air goes up, fluid goes down. So it's really just it's that simple. That's all you need for now. There'll be much more coming up on that. Ventilation perfusion ratio can be calculated by dividing the ventilation by the perfusion. In a lot of patients, it turns out to be roughly 0.8, which is another way of saying, there's the 0.8, another way of saying that the system's not perfect. If the system was perfect, we would have a VQ ratio of 1, but that does not happen. So alveolar ventilation is about 4 liters per minute, and capillary blood flow about 5 liters per minute, comes out 0.8. It does vary different from different parts of the lung to other parts of the lung. And there we go. We see the ventilation perfusion ratio in zones 1, 2, and 3 just depicted on a graph. Starling's law is the interaction of 4 forces: hydrostatic pressure in the capillary, hydrostatic pressure in the interstitium, that's the area outside the blood vessel, oncotic pressure in the capillary, and oncotic pressure in the interstitium. These forces interact by 2 mechanisms, and what it has to do with is how the heart generates flow, and it's the interaction of these pressures that does that. This is capillary fluid dynamics that control fluid balance between the capillary and the surrounding tissue. Let's say your heart is in failure, you're in congestive heart failure. Then what happens is that fluid backs up through the system, backs up through from the left ventricle to the left atrium, and then back up through the pulmonary veins and into the lungs, where unfortunately that fluid starts to fill up the alveoli. That's congestive heart failure. And that's the essence of what's going on when the heart is failing. If it's bad enough, we call it pulmonary edema. Pulmonary edema, which is severe congestive heart failure. There are other reasons that patients get pulmonary edema, and we'll talk about those in the disease class. Capillary fluid dynamics is more than you need to know. You just do not need to know that. Starling's equation, and there's pulmonary edema, which I was just talking about. So this condition caused by hydrostatic pressure in the pulmonary capillaries, whenever the vasculature is overwhelmed by the volume of fluid passing through it. And that essentially means the heart can't keep up, and we get cardiogenic pulmonary edema. associated with left heart failure. And that causes the wedge pressure to go up. The pulmonary, this because this is definitely a board question, the pulmonary capillary wedge pressure goes up in cardiogenic pulmonary edema. Normally, the wedge is between 4 and 12. If the heart's failing and they're in pulmonary edema, they might go up to 20, 25. Lymphatic insufficiency can also be a factor. You know, your lymphatics do a really important job of gathering up fluid and returning it to the circulation. If you want to see how important that is, just see a patient who has had their lymphatics removed. Maybe they had a cancer and they had to have their lymph nodes removed. They will have difficulty with fluid building up from then on. So it is, lymphatic insufficiency is a big issue. High permeability pulmonary edema is toxins cause an increase in the permeability of the pulmonary capillaries. There are a variety of different toxins that can do that. Many of them are associated with bacterial infections. Oncotic pulmonary edema is where the oncotic pressures are abnormal. Low blood protein levels can cause that and also wind up with fluid in the lungs. All these different things that can cause fluid to accumulate in the lungs. Re-expansion edema, poorly understood, but we think what happens is when an individual has a large pulmonary effusion or pneumothorax, it's relieved, then the lung is rapidly reinflated, and sometimes they get pulmonary edema as a result of that. So it's the rapid reinflation. Now, we still have to go ahead and do that, but we just have to realize that there may be some edema, some fluid in the lung that happens with that. And sometimes we just don't know why. What's called idiopathic. When I think Dr. Vega mentioned that word, idiopathic, my professor said we're idiots about it. We're idiots about it. It's idiopathic because we don't know why it happens. High altitude is one thing that sometimes does this. I think it's interesting that the guys who finally reached the top of Mount Kilimanjaro, they did it by taking respiratory therapy equipment up to the last base camp before their final move to go to their final ascent, I think they call it. And what they did is they BiPAP'd themselves overnight to get their lungs as clear and as oxygenated as possible before they made that final push up the mountain. Fascinating. Summary: systemic and pulmonary circulatory blood pressures are measured and are very important. We know that systolic should be about 120, diastolic about 80. So many Americans have high blood pressure, as you know, and we have to take medication for it. And um, it's just very important to monitor your blood pressure and take care of that because if it goes on for a long time, high blood pressure can damage a lot of things in the body. Pulmonary arteries are about 25 systolic and 8 diastolic. Those are pressures that you will use in your critical care class, so you might as well learn them now. Pulmonary arteries about 25 over 8, and the mean 15. I'm saying this again because I know it's on your boards. Greater than 25 is pulmonary hypertension. There we go. Actual pressures in the capillary, not well known. We use 4 to 12 at the hospital, but the physiologists say 7 to 15. It's something close to that. Let's go 4 to 12 because that's what you're going to see in critical care. 4 to 12 is normal. Pulmonary arterials about 12. Pulmonary veins, we don't use that number, so why would I bother you with it? Pulmonary blood flow at rest is about 5.4 liters. It can increase during exercise to maybe 30 or 40 liters. We have a remarkable ability to respond to physiologic stress. Pulmonary vascular resistance is any impedance to blood flow, and it can be serious, but we do have good ways to treat that. One way to treat that is with inhaled nitric oxide. The device is called an Inomax. You will see it very soon in clinic, and it is inhaled nitric oxide. Folks, that concludes Chapter 8. You'll know a lot more about this in future courses, but I think it has been useful to, give you an introduction to it here. I'm now going to post this as an announcement. Wish you success on your midterm, and one more reminder, use that review sheet. I try to be, very fair with students about telling them what they need to know, and if they know it, then they'll do well on the midterm. All right, thank you very much.